Usually when when an academic gives a talk in front of peers, even if they agree with you, they won't let you know, and the audience is, you get points for making zing questions, and so it really is a pleasure to speak to a friendly audience for a change. And my work will be really easy because this question, which comes first, overeating or obesity, was beautifully answered by Gary Taubes yesterday. So many of these concepts are going to be very familiar at this point. So my job will be just to dig down a little bit deeper into the research data and build a broader case. And these are my disclosures. Well, the first law of thermodynamics holds that energy can neither be created or destroyed, and applied to living systems, we have the familiar equation, calorie intake minus expenditure equals calories stored. And since in humans, most of our excess calories are stored in fat, we can change the right side of the equation to fat mass or adiposity. According to the conventional interpretation of this law, obesity is a personal failure to control their energy balance. So in our modern food environment with ubiquitous tasty foods, it's easy to overconsume, take in too many calories, but because of the absence of opportunities for physical activity, recreational and lifestyle, those calories build up in the bloodstream. They don't get burned off. They build up as calorie-rich substances like glucose and lipids, and they get forced into fat cells, making them anabolic or making them grow. So the simple solution, of course, is eat less and move more. The conventional view places the responsibility squarely on the individual to control energy balance. This is from the USDA MyPlate website. Reaching a healthier weight is a balancing act. The secret is learning how to balance your energy in and energy out. And if you like the energy balance approach to obesity, you're going to love a low-fat diet. Fat has twice the calories per gram of carbohydrate and protein, and this notion was one of the main design principles for creation of our first USDA Food Guide Pyramid of 1992. We were told to eat all fat sparingly, avocados, nuts, fatty fish, all full-fat dairy. They should all be consumed sparingly, and instead we were supposed to load up on those mostly processed grains. Remember how many servings? 6 to 11 servings, and if you add in those little potato, you could get up to 13 servings a day of starchy foods and be in full compliance with recommendations. Now, this notion of a low-fat diet was inspired specifically out of considerations of energy density. The Surgeon General's report in the 1990s placed specific primary emphasis on reducing dietary fat because of its high calorie content, whereas sugar was really just a secondary concern for groups like children who were at risk for dental caries. Now, colleagues, the nutrition establishment doesn't like to, has a remarkable amnesia about this. Just 20 years ago, extreme statements were made in favor of carbohydrates and against fat. These are quotes from society leaders published in leading medical journals. One team said, when people are allowed to eat from ranges of high fat or high sugar foods, passive overconsumption only occurs with fat. It follows that fat promotes overconsumption, while sugar probably prevents it. Another team said the evidence intriguingly suggests that it is specifically an increased intake of sugars, rather than complex carbohydrates, that dilutes fat energy. And a third group said by decreasing the ratio of fat to carbohydrate, eating less fat and more carbohydrate, you can get balance with less emphasis on the carbohydrate source. You don't have to worry about the quality of the carbohydrates you're eating. Just eat more of them, all of them, and the problem will be taken care of. The government joined in on this quest. This is the Healthy People 2000 goals that called on the food industry specifically to market thousands of new processed foods that were low in fat and saturated fat. So if you're going to take out the fat, what are you going to replace it with? If it's a processed food, sugar and refined starches. And we got an invasion of the food supply with these products. Now, the apologists of the conventional view like to say there was no problem with nutrition recommendations. There was no problem with the government's advice. It was the public. They misunderstood our approach. We meant that they should be eating more fruits and vegetables, and instead they took this as license to eat junk food. But that's selective amnesia. You know, I've never been a big defender of the food industry, but the food industry responded to calls from the government and from nutrition experts, and the public was doing what they were told. You know, and I think it's important not to forget this history, because if we forget it, you know, we're going to be doomed to reproduce it, to relive it. So as a result, proportion of calories went up as carbohydrate, down as fat, just as intended, and the obesity epidemic developed over that time period. Now, this doesn't prove cause and effect, but these meta-analyses of clinical trials suggests that our recommendations to reduce dietary fat actually were not just misguided, they actually importantly caused the problem. In each of these cases, whether the comparator group was a medium-fat Mediterranean diet, a high-fat, low-carb diet, or a ketogenic diet, in each of these cases, the low-fat diet was inferior to the higher-fat diet, opposite to what was predicted. We know that very few people can lose weight and keep it off for the long term. In adults, in children, the situation is just as bleak. Very few, you know, the situation is marked by small changes in weight and substantial relapse. So we have to ask, why is this paradigm? It's so simple, right? Just eat less, move more. Why has it failed? Well, one obvious problem is it completely neglects virtually a century of research to indicate that body weight is importantly controlled by biology, a complex interaction of crosstalk among key body organs, hormones, metabolic signals, neurological influences that serve to control weight. We know, for example, that when a person, whatever their weight is, lighter for a lean person, heavier for someone with obesity, whatever that baseline weight is, when you put that person on a low-calorie diet, cut back calories, at first they'll lose weight. That's just a law of physics. But what happens? Hunger increases, and if you ignore hunger and try to keep eating less, your metabolism's going to slow down. Your body's going to fight back against calorie restriction, and that's inevitably, for most people, going to push them right back to where they started. But the opposite's also true. When individuals are overfed, you know, in these classic force-feeding studies, you know, the volunteers to these studies would think, this is great, I'm going to get paid to eat 1,000 extra delicious calories a day. But they quickly realize it's not such a great bargain. After a few days of overeating, they lose all interest in food, and their metabolism speeds up in their body's attempt to get rid of those extra calories. And so they, too, come right back down to baseline, giving rise to this notion of a body weight set point, which we intuitively sense must have something to do with our genes. But if we do have a set point, we have to ask, why is this defended level of body weight crept up year after year? Why did a typical man of 5'9" happily maintain a body weight of 160 pounds in the 1960s? If you force-fed him to gain weight, he would have come back down to 160. But today, that same typical man is defending a weight of 185 or 190 pounds. So why is that? What can we do about it? Well, we're not going to get any answers from the conventional calorie balance view. This conventional view may acknowledge that body weight is controlled by biology, but it lacks any kind of compelling biological explanation for the obesity epidemic, beyond saying that it's difficult for people to control their behavior in the modern food environment. There are no testable hypotheses for why the set point is going up. And with this insistence that all calories are alike, treatment inevitably devolves back to what? Eat less and move more. Well, we know that this relationship between energy intake, expenditure, and fat storage can't be wrong. That's a law of physics. But maybe, as Gary Taubes suggested yesterday, our assumptions of causal direction were the problem. Maybe the arrows don't flow from left to right, they flow from right to left. Now, this also doesn't violate the law of thermodynamics, but it has a fundamentally different implication to obesity treatment. According to the carbohydrate insulin model, something has triggered fat cells to take in and hoard too many calories, leaving too few for the rest of the body. The brain perceives that, and that's why we get hungry. And if we neglect that, if we keep trying to restrict calories, energy expenditure declines, we get fatigued, we're less likely to be physically active, more likely to collapse on the couch, our resting energy expenditure decreases, muscles work at different efficiencies. So from this perspective, the recommendation to eat less and move more misses the point and can actually make the problem worse. If the problem is there aren't enough calories remaining in the bloodstream to nurture the brain, which we heard so much about yesterday, and the body organs, then further attempts to establish a negative calorie balance are going to make people feel worse. And that's why people fall off diets and feel terrible on diets long before their weight loss goal is in sight. If somebody 250 pounds loses 20 pounds, their body's going to be fighting back, even though they still have plenty of calories on their body, too many calories. But their body's fighting back because those calories are locked away in the cupboard. Like, what is it? The calories check in, but they don't check out. And they're not doing any good if they're stuck in the fat cells. The brain thinks it's a question of starvation. So what could be triggering fat cells? Well, the obvious player is too much insulin. I call insulin the miracle grow for your fat cells, just not the sort of miracle you want happening in your body. Insulin regulates the availability of all of the metabolic fuels. It stimulates fat synthesis and deposition. It limits release of fat from fat cells. We know that states of excessive insulin action, now not levels, because there can be also insulin resistance, so you have to think of insulin action. States of excessive insulin action consistently lead to weight gain, such as starting someone with type 2 diabetes on insulin, or an insulin secretagogue. That's going to cause weight gain. But the opposite's also true. Without enough insulin, you can't gain weight. A child with type 1 diabetes, which is an autoimmune condition, which makes the body unable to make enough insulin. When that child first comes to attention, she will have inevitably lost weight. That's one of the key presenting features of type 1 diabetes. She might be eating 3,000, 5,000, or 7,000 calories a day. Weight loss is inevitable with new onset diabetes until insulin treatment is started. Give the right amount of insulin, weight trajectory returns to normal. Give the child too much insulin, and excessive weight gain occurs. Now, if you, and some studies by Robert Lustig on insulin blocking drugs are also part of this story. If you don't have diabetes, the quickest way to change your insulin levels, without just eating less, is based on the amount and type of carbohydrate you consume. And in terms of the type, glycemic index is relevant. It's not the whole story. We really need the two together. Glycemic index takes into account how foods with the same amount of carbohydrate influence blood sugar. So it's going to distinguish white bread from beans or berries. You can have the same grams from those two foods, and most people, although there's going to be variation, as we know from the Israeli studies, but most people are going to have markedly different on average, glycemic responses to those kinds of differences. So when you put them together, you have glycemic load, and that means, you've heard it, the processed grains, potatoes, and added sugar versus, depending on your capacity to handle it, and we'll come back to this, minimally processed whole grains, whole kernel grains, whole fruits, beans, and dairy. And so this concept of glycemic load takes into account most of the variation in blood sugar and thus insulin levels after the meal. So what happens after meals differing in glycemic load? In this study, we looked at 3 meals with identical calories in adolescents with obesity. One was instant oatmeal with a little milk and sugar. That was actually a whole grain meal and low fat, just as recommended, but instant oatmeal digests very quickly. Versus steel cutouts. That's an old-fashioned preparatory method. The kernel is intact. I think it's tastier. Nobody has time for it these days. But those 2 comparisons had the same protein, fat, and carbohydrate. And then we also had a vegetable omelet with fruit that had no starch or added sugar at all. And so this is what happened during the 5 hours after the meal to 2 key hormones. Insulin, which we've talked about, is, of course, higher after the high glycemic instant oatmeal than after the other 2 meals. But glucagon, now that's a key hormone we don't think a lot about, but it's the yin to insulin's yang, or the yang to insulin's yin, I'm not sure which. But it does the opposite. Glucagon pulls calories out of storage. And so if you have too much anabolic hormone, too much storage from insulin, and your glucagon is suppressed, which a high glycemic load meal will do, that's a metabolic double whammy. Those calories are going to get locked away very avidly. And so you can see that after the meal, blood sugar initially surges after the high glycemic index meal, but then comes down into a relative hypoglycemic range. And that's not all. Free fatty acids, which are a key metabolic fuel, are suppressed to a greater degree after the high glycemic index meal. So the time period of interest isn't 1 hour. 1 hour after the bagel, fat-free cream cheese, and orange juice, you're feeling great. Your blood sugar is surging and, you're happy. It's what happens 3 or 4 hours later. So these very short-term studies miss the boat here. And that's the time when you're going to either eat an extra snack or an extra large meal, or your metabolism is going to be affected. And was this just a laboratory curiosity? Look what happened to epinephrine, adrenaline, an emergency stress hormone. Same calories at baseline, but in one case, epinephrine was surging. In the other 2 cases, the body was hormonally happy. And if your blood sugar and free fatty acids are low enough to trigger this stress hormone response, what's that going to do to hunger? It's going to increase it. And when subjects we gave them free access to food in a second meal, they ate 600 or 700 calories more after the instant oatmeal. Now, if a small fraction of that difference were maintained meal after meal, day after day, it would explain much of the obesity epidemic that arose as these processed carbohydrates entered our diet. So what's happening in the brain as blood sugar is crashing? Well, to look at this, we used a new technique called functional MRI, specifically arterial spin labeling. We did this in a double-blind fashion, in this case with 12 men with overweight who were given one of 2 milkshakes. They got both on different days, masked. So they, nor the investigator that day, knew which was which. And the milkshakes had the same protein, fat, and carbohydrate. One was low glycemic index with uncooked cornstarch. That's a very slow digesting carbohydrate that's used for some metabolic diseases. And the other had corn syrup. So it's both glucose polymer, it's glucose, no fructose in any of this. So we're just focusing on glucose, either slow digesting glucose or fast absorbing high glycemic glucose. So as expected, the fast-acting milkshake with the corn syrup caused a rapid rise of blood sugar, and then it came down. At 4 hours, the pre-specified time point of interest, people said they were hungrier after the fast-acting milkshake. And at that time, one area of the brain lit up like a laser. This is the nucleus accumbens. Nucleus accumbens, and this occurred in every subject. I've never done a nutrition study in which every subject responded the same way. So we had very high statistical power to take into account comparisons throughout the brain. Nucleus accumbens is considered ground zero for the classic addictions of cocaine, heroin, abuse, alcoholism. It's the center of the dopamine striatal pleasure and reward system, raising a provocative concept of food addiction. Now, of course, we need food to live, but it suggests that these highly processed foods, but specifically the highly processed carbohydrates, are driving cravings and potentially addictive behaviors, not because of their tastes. I should say these two milkshakes were designed to have the same sweetness, and it was 4 hours earlier. It's not because of the tastes. I mean, think about it. Plain, baked potato chips, plain popcorn, bagels, these binge foods. Nobody binges on butter, right? You binge on the processed carbs. Are they really that tasty? I mean, most people would say that butter is tastier than white bread, but they would binge on the white bread, not the butter. So it's suggesting that food addiction might be a real thing, but not because the food is so tasty. It's because of the biological impact of the food on our metabolism, potentially hours later, because of how it's affecting our hormones. All right, let's turn to an animal model where we can control things a little bit more completely. And this is Sprague Dolly rats that we were giving them, again, low or high glycemic index diets, same carbohydrate, again. So we're going to come back to low carbohydrate, but this affects even at higher amounts of carbohydrate, just controlling carbohydrate quality. So we pair-fed them to keep their weight the same. And you can see on the panel on the left that over the 18 weeks of the study, which is like 7 rat years, the animals maintained the same average weight. But to do that, we had to begin to restrict calories in the high glycemic load group at about 7 weeks. What does that mean? Well, the high glycemic group started gaining weight faster on the same calories. And so what does that imply? That metabolism is slowing down, just as predicted. So we did what you're supposed to do. We put the animals on a diet and prevented excessive weight gain. And despite the fact that we were able to prevent excessive weight gain, which is something that's rarely accomplished in humans, they had 70% more fat. Same weight, 70% more fat, so they're going to have less lean tissue. Now, I'm glad that we're not talking right after lunch. This is my one graphic slide. These two animals weighed the same. The animal on the left had a low glycemic index diet and was metabolically healthy. The one on the right's belly filled up with the highest risk fat depot, and its diabetes and heart disease risk factors were sky high. There's no way this finding can be explained by the conventional calorie in, calorie out model of obesity. That animal on the right was gaining weight excessively, so we did what you're supposed to do. And despite that, it was a metabolic mess. Does this finding apply to humans? We looked at 21 young adults with obesity. And what we did was we monitored them, then we put them on a weight loss diet to lose 10% of their weight at least, and then we stabilized them, and then put them on one of 3 diets, either low fat, high carb, or the other extreme, Atkins, very low carb, or sort of a Mediterranean diet, 40-40. And we saw, as expected, that the low-fat diet in the late postprandial period, 3-4 hours after the meal, caused this drop-off in total metabolic fuels. Total, if you add up all the calories in the blood, you're fine at 1 hour, 30 minutes in an hour, but at 3, 4, 5 hours, there's that drop-off. And then when we measured total energy expenditure with doubly labeled water, remember this is a crossover study, so everybody got all 3 diets, when they were eating the low-fat diet, their calorie burn had dropped by more than 400 a day. On the low-carb Atkins diet, it didn't drop statistically at all. It's like the body didn't know it had lost weight, and so wasn't adapting. And that's a really good thing. This difference of 325 calories is pretty much the whole obesity epidemic. I just want to point out, we saw something else that was interesting, that the beta cells calmed down when they were on the low-carb diet. When we gave an oral glucose tolerance test, the time to peak insulin and the peak of insulin were all lower. And we saw also that if people got the low-carb diet first, then they didn't react badly to the low-fat diet, to the high-carb diet. It's as if, and so it implied that there is persistent benefit of a low-carb diet even after you stop eating it that may help you tolerate a higher carbohydrate diet. So maybe if you just get off of all processed carbs, go really low carb for a few months, you may be able to add back some more carbohydrate and tolerate it in ways that you couldn't before. Don't know how long it will last, but it's just, it's an interesting finding. So why aren't we using this approach in weight loss clinics across the country? Why aren't public health recommendations focused on this? Well, two reasons. One is the metabolic studies, and the second is the behavioral studies. Metabolic studies such as this by a group at the NIH that took 19 adults with obesity and on a crossover fashion put them on a lowish carb diet, 30% carbs, versus an ultra-low fat diet, 8% fat. There's plenty of historical populations that ate very little, that ate 5% or less carbohydrate. I don't think you could find any natural populations that would be eating 8% fat. But that's what they did. And note that the study was 6 days long. And they found that there was no difference in energy expenditure. We didn't get at this metabolic benefit on the low-carb diet. And if anything, fat oxidation was worse on the low-carb diet. So these studies flood the literature and are dominating the mindset of nutrition research today. But there's an obvious limitation, which is that the physiological adaptations to a low-carb diet don't happen immediately. We've heard about this already. Fasting, which is a very potent stimulus to ketogenesis, even during complete fasting, such as the classic studies of Cahill and Owens, ketones take a couple of weeks to reach steady state, and there may be ongoing changes after that. 6 days, you're only halfway there. The same is true for ketogenic versus non-ketogenic diets. Takes a couple of weeks. After 6 days, your body is still adapting. And so there's many studies are demonstrating this. And so if you cut down carbohydrate, if you're adapted to carbohydrate, your brain's dependent upon glucose, and you quickly eliminate carbohydrate from your diet, what happens as your body is, before your body reaches steady state ketones, what do? How do you feed your brain? Well, you have to borrow from your muscle. Through gluconeogenesis of amino acids, you produce enough glucose to get your brain by during that time. But your nitrogen balance is going to be negative. You're going to be, in a not great metabolic state. Maybe exogenous ketones could be useful to help this transition. But look what happens to nitrogen balance. On a ketogenic diet, people are in more negative nitrogen balance, but it's temporary. They come back to balance after about a month. In 2 or 3 months, who knows what happens? It may go in the other direction. And so even one of the chief critics of the carbohydrate insulin model published, if you look carefully at a figure in one of their studies, you can see that first minus 15 to 0 was the time on a standard diet, and fat was decreasing. And then they put them on a ketogenic diet, and the rate of fat loss decreased. They make a big deal about that. But they kind of ignore what happens during the second 2 weeks, which is the rate of fat loss picks up. What happens after 30 days? It might get even faster. We know there are dozens of studies in animals and in humans demonstrating that the process of adapting to a ketogenic diet takes a while, takes 2 to 3 weeks at least. Thanks to Steve Finney, found this great quote. We've known about this for 150 years at least. Schwatka did an Arctic voyage to search for the lost Royal Navy Franklin expedition. And he said, because up in the Arctic, you're not going to be eating bagels. He said, when first thrown wholly upon a diet of reindeer meat, we're talking basically a very low carbohydrate, if not a ketogenic diet, it seems inadequate to properly nourish the system. And there is an apparent weakness and inability to perform severe exertive fatiguing journeys. But this soon passes away in the course of 2 to 3 weeks. What do we call it today? The keto flu. So these very short-term studies really provide no information about the long-term relationships between macronutrients and metabolism. And it's sort of like, my favorite analogy is like, suppose researchers wanted to look at the benefits of intensive physical fitness training. They took sedentary middle-aged adults and they put them into boot camp with calisthenics and running and contact sports 6 hours a day. 3 days later, they measured them. What would they see? Well, they're tired, their muscles are sore, they're weak, their physical abilities have actually declined. So do we conclude that fitness training is bad for your physical abilities? No, we just say we need longer studies. But this is a mistake that's consistently made in nutrition. We have just finished a 20-week study, so 10 times as long. And it had 164 people. It was funded, it's a $12 million study funded by NUSI. I'm not at liberty to present the results today, but we will be presenting the results at the Obesity Society meetings November 14th. And I encourage any of you to come and come join us there. And we will hopefully have the results in press around that time. So that we hope that the study will inform longer-term understanding of these macronutrient relationships. Okay, so what's the other criticism? It's the behavioral studies. These are long-term. What do? You take people and you assign them to one diet or another diet, and you give them some behavioral counseling, and you say, go off, eat this way. Such as, I think the poster child for this kind of study is the pounds lost study. 800 people, that's a lot for a nutrition study, put on diets ranging from 35 to 65% carbohydrate, 20 to 40% fat, 15 to 25% protein. This isn't as broad a difference as you can get. It's certainly not a very low carbohydrate diet, but if you don't see anything through this range, maybe you could fairly say, well, what's the public health relevance? And again, so this is individual and group counseling. And they report no difference in weight in any group. The off-stated conclusion of this study is that diet doesn't matter. The only thing that matters is compliance. Choose any diet, you'll stick to it, and it'll work. That's an erroneous conclusion for a simple reason, that these behavioral studies consistently have a major flaw. They don't achieve the targeted dietary goals. In Pounds Lost study, the self-reported maximum difference in the nutrients was less than half the intended difference. Even these small differences are likely to be overstated due to what's called social desirability bias. Let's say I recruit you to be on a low-fat diet study, and I pay you financial compensation, I select you for your ability to comply, and then I ask you, what are you eating? What are you going to say? A low-fat diet, regardless of what you're actually eating. The biomarkers in this study suggested little, if any, significant persistent difference. Triglycerides are a sensitive marker of carbohydrate intake, no difference at any point in the study. Nitrogen excretion for protein, no significant difference at any point of the study. So the obvious limitations of these studies are that they really are not sufficiently intensive to fairly test a dietary hypothesis. There are a few studies that tend to do this right. such as the direct study. You've already seen the results, so I'm not going to belabor this. But this was conducted at a nuclear power facility in Israel where people would check in the morning and stay there all day because you probably had the big procedure screening in and out. And so they could control lunch, at least one meal. And they got significant, reasonably meaningful differences, not huge differences, but then they didn't control all of their meals. And the Diogenes study, which I won't take the time to discuss now. So I've argued that the dietary carbohydrate that's flooded the food supply during the low-fat years has increased insulin secretion, triggered fat cells to hoard too many calories. That causes too few, not too many, circulating fuels in the bloodstream. And that's why we get hungry. That's why metabolism slows down. But this isn't just a single nutrient, single hormone hypothesis. There are many components. It provides an intellectual infrastructure for understanding how multiple components of our diet, fatty acid, types, amounts, prebiotics, probiotics, micronutrients, the gut microbiome, protein amount and type, and non-dietary factors, which all directly influence adipocyte behavior, could determine our risk for obesity, could influence our ability to gain or lose weight. And also of concern are these environmental pollutants that are endocrine disruptors, which have frightening effects on fat cells, specifically on fat cells, differentiation and behavior. Outcomes beyond body weight, diabetes. This study by Laura Saslow was recently mentioned, I think this morning, so I won't belabor that. We did so diabetes, of course, is a condition of carbohydrate intolerance, and so it doesn't seem that big of a stretch that reducing carbohydrate would be helpful. But the concern with type 1 diabetes has always been ketoacidosis. Because in that, we all heard, you don't go into ketoacidosis if you're healthy on a low-carb diet, except in extreme, very rare situations. But there's no protection there in type 1 because you don't make enough insulin to turn off ketosis. Ketones feed back on insulin and create a negative homeostatic loop. But in type 1, there's a big concern of ketoacidosis. People die of ketoacidosis. So there's been a big fear of it. But there's a large, mostly underground community, this particular Facebook group following Dr. Bernstein's approach. We got permission to survey the community, do a scientific study. And we found that their mean, and this is about half children and half adults. The adults, the children were represented by the parents in the survey. Mean carbohydrate intake was very consistent with a ketogenic diet, a very low-carb diet, although their protein intake was higher than a classic ketogenic diet. They focused more on protein. Their mean insulin dose was very low for type 1 diabetes. They had the classic lipid panel, high LDL, but also high HDL and low triglyceride. Look at that, 1-to-1 ratio of HDL to triglyceride. For type 1 diabetes, that's impressive. Low, not high rates of hypoglycemia and DKA. They did not seem to be at increased risk for DKA. High satisfaction. And look at this. This was our primary endpoint, hemoglobin A1C. Average was in the normal range. That's unheard of for type 1 diabetes. If you come into the doctor, as many of these families do, and they find out you've got a hemoglobin of 5.5, if it's a parent of a child, the parent gets a lecture that they're running them too tight and they're at risk for severe complications. These people know not to listen, but it sets up a problem. And the problem is that the patients are doing one thing and not talking to the doctors directly. And the doctors are, thinking something else and lecturing their patients, and that's actually a setup for catastrophe. Because, these patients, no matter how sophisticated they are, they're still not physicians, and there are still things they don't know about management of type 1 in disease. And so I think that we hope that the study we published in Pediatrics will help start a dialogue so that these patients don't feel like they have to be stigmatized and have to hide. And ultimately, we need randomized controlled trials. We don't know from this observational study long-term safety. I'm going to just skip over heart disease. Well, I'll just mention that another concern is, all right, maybe a low-carb diet will help you lose weight, but you'll be a good-looking corpse. Your arteries are going to fill up with fat, plaque. Well, the two major studies of low-fat diets were flops from a cardiovascular disease perspective, the Women's Health Initiative and the Look-Ahead study. In fact, the Look-Ahead study had to close early for futility. You never want to hear that term if you're an investigator. Your study is futile. Resistance is futile. Why hasn't the government funded a single big multi-centered low-carb diet study? We don't have any. But we do have EPI. Now, I know to some people in the low-carb community, observational research is quite a dirty name, but there are limitations to clinical trials, as I've shown. I mean, those behavioral diet studies have major limitations. And while there's a lot of problems with EPI, I think there's a way to do EPI right that can really minimize concerns for confounding. And in this particular study, I would say this is a study that's at low risk for confounding, at least because the confounding would go in the other direction. Healthy people were consistently eating a low-fat diet. So the health halo effect would tend to bias the low-fat people to longer lifespan, and in fact, the opposite was seen. That the lower the fat you were eating, the higher your risk for premature death. So that gives you pause. We've heard about ketones having a variety of biological effects through other pathways, not specifically insulin. So in summary and conclusion, the conventional approach to weight loss, the low-calorie diet, has poor efficacy in an environment with unlimited food availability. Yes, if you're an impoverished Chinese peasant working 12 hours a day, you're not going to get obese you're not going to develop obesity on a high-carbohydrate white rice diet. But that's not what's happening here. And in China, as the peasants are moving to the city, bringing their high-carbohydrate diet, but leaving behind their physical activity levels, we have a massive epidemic of obesity and specifically type 2 diabetes. An alternative approach aims to reduce anabolic drive, leading to reduced adiposity ad libitum. Now, that's got to be appealing. And this can be achieved by lowering total carbohydrate or glycemic index, or both, and other qualitative aspects of diet. It's not just carbohydrate. The findings from the feeding study have to be, the short-term feeding studies, I think you just got to chuck them. And, we need longer studies to see what really the effects of these macronutrients on metabolism. The behavioral studies have to be interpreted cautiously too, but we can do them better with intensive support to help people really change behaviors. Give them cooking classes. If they're financially stressed, help them, deliver parts of their diet. You could deliver olive oil and avocados and make it easy, and or even send a personal counselor or personal chef to the home. These are not expensive interventions in the context of the costs of obesity, diabetes, and heart disease. So we've got to do these behavioral studies better. And we want to also look at whether ketogenic diets have unique benefits above and beyond less restrictive regimens. So Gary Taubes offered a quote from 1942, and I'm going to best him with this. And here's the quote. the editors of a leading journal wrote, when we read that the fat woman has the remedy in her own hands, or rather between her own teeth, so this is the editors citing some other article that was written that clearly had an element of snark. There is the implication that obesity is merely the result of unsatisfactory dietary bookkeeping. Although logic suggests that body fat may be decreased by altering the balance sheet through diminished intake or increased output or both, the problem is not really so simple and uncomplicated as it is pictured. So Gary's quote was from the 1940s. This was from 1924 by the editors of JAMA. And so follow me on social media, and thank you for your attention. On time.
On time, right on time. So we have plenty of time again for questions, and we can get started right down here.
Hi, Dr. Ludwig. What advice would you give to primary care?
Do you mind just saying who you are and where you're from?
Jeff Capodanno. I'm a nurse practitioner, work in an ICU. But my wife is a primary care physician, works at Kaiser, and frequently gives people advice to eat low-carb diets, but has endocrinologists and cardiologists that don't follow that advice that she refers patients to that would probably think she's crazy. And organizations like the ADA that recommends 50% of calories from carbohydrates to diabetics. So what advice would you give to primary care physicians that have these obstacles in front of them?
Well, actually, just to modify the last things, the ADA was recommending, the American Diabetes Association was recommending diets as high as 60% carbohydrate in the 80s and 90s. But that's changed. Now they've retracted any specific macronutrient recommendation, although there still is a bit of a schizophrenic mindset, because they say you individualize it, there's no one ratio, but they say start with, I think it's 45 grams of carbohydrate per meal and work from there. And if you add in snacks and so forth, you're talking about a significantly high carbohydrate diet. I think we're living in a field with emerging science. And we didn't talk today about individual differences. I think there's clearly individual differences. I'm very interested, my group's very interested in how insulin secretion, people who are high insulin secretors, they look more like apples than pears, are uniquely sensitive to carbohydrate, whereas the low insulin secretors may do reasonably well on a broader range as long as you focus on nutrient quality. We don't know if there's downsides to for some people with very low carbohydrate or ketogenic diets. I think I certainly agree with the other speakers that when you're talking about type 2 diabetes or severe insulin resistance, the likely benefits are likely going to far exceed any theoretical risks. But I think we have to just keep doing research, get the findings out there, and let clinicians use their best judgment. We're also seeing patients in the public jumping over the clinicians because the four, I'm not going to be jealous about this, but the four best-selling Amazon diet books are all ketogenic diets right now. So the word is getting out. My goal is to pursue the science so that we can all start moving in the same direction and not have this polarization with different sides not talking to each other. That does not serve science.
Hi, I'm Elizabeth Walton, an internist in Atlanta. My question is, are there any adverse effects seen with the ketogenic diets in people with mental health problems, particularly depression, anxiety, bipolar disorder? I'm seeing in my practice tremendous improvement in anxiety and improved mood and decreased medication use for that kind of stuff. But I've heard some mental health providers caution about it, especially the beginning phase when that keto flu.
Yeah, I think that's a fair, so the ketogenic diet is, again, the most extreme version of this. There are ways down there that aren't going to get you into, so phase one in our diet program is 25% carbohydrate. We wanted to go as low as you can without getting people in and out of that keto range. I mean, I kind of think you have to either, if you're going to go below 25%, you just got to go for it and deal with it and get through it. So yeah, that could be an issue. But the conventional diet is producing a hormonal storm with every meal. You know, you have this massive, we're supposed to have a little anabolic effect after we eat and then a little catabolic effect later. You know, instead we have this massive anabolic effect when we eat processed carbohydrates that for many people lead to a massive catabolic effect of stress hormones. And so the body's being yanked in every direction, and that can't be good for the brain. You know, we know that chronic inflammation can set in. I've gotten hundreds of reports, you know, even on the 25 to 40% carbohydrate diet that we provide in our program, you know, focus on unprocessed carbohydrate. But we get hundreds of reports of people who are giving up their depression medications. They are feeling less anxious, more socially confident. You know, I guess there's selection bias, because if people are doing poorly, we might not hear about them. But it does stand a reason, and I would say the bottom line is if somebody's got a major psychiatric issue and you're considering a ketogenic diet, you want to just be mindful of potential complications.
Hello, I'm Catherine Price. I'm a science journalist and I have type 1 diabetes, so I appreciate your work greatly. But I had a comment and a question on the journalistic side of things, because a number of people have been asking about how to interpret headlines that seem to directly contradict what we're hearing here. And the comment is just from a journalistic perspective, it's interesting, someone pointed this out to me, that if you're someone who knows what you're talking about and you look at a study and you see it's bad, and then you might say it's not worth covering. And so that you don't actually write a critical article about it. But if you don't fully understand it, and it says that keto's killing people or whatever, you're more likely to write about it. So there's this weird amplification that happens where responsible writers are not writing the stories, and as a result, you get these inaccurate messages. So that's my comment. But my question to you, we've kind of danced around numerous times what the major limitations of some studies are to look out for. But I was hoping you, and perhaps the next questioner, could outline some bullet points from a consumer's perspective of things that you should immediately look at when you're reading an article about a nutritional study, let's say a low-carb diet study, that can help you evaluate whether or not that message is actually worth believing, so that all of us can become better ambassadors of being able to explain or answer friends and family when they're like, well, what about that headline?
It's a great question. I don't think I could do it anywhere near justice. I mean, that would be a whole conference, how to interpret science, you know, properly. And that's why ideally you have science journalists who actually know something about science, beyond just regurgitating the press release, which is oftentimes hyperbole. But just to summarize the two issues that we talked about today, if it's a feeding study and it's short and it's making claims about long-term macronutrients, chuck it. If it's a behavioral study and it's long-term, but they don't show that the two groups are eating any differently, you know, chuck it. But I shouldn't say chuck it, because there's no perfect study, and we can learn from failure. You know, failure can be very instructive if we get our egos out of the way as scientists. Unfortunately, that's not always the case, but if we do a study and we put it out there and somebody comes with a really good criticism, rather than going into denial about it or setting up camps, you know, we say, all right, I think maybe your criticism is a little overstated, but here's the points that are correct about it. Here's how we could now better design a study. Let's work together as friendly opponents and do it right. That's what science should be. It's disappointing that it's not so often the case.
David, I'm surprised you didn't bring up the fact that the study you did with Lenny Lesser showed that the odds ratio for a study being favorable to the food industry was 7.61 if the food industry paid for it. So that's the first thing you do, is look at the funding. And if the funding is from a food industry, chuck it. I actually have two comments. So David, you had you mentioned the pounds lost study. And the pounds lost study was kind of interesting, because if you look at the data, it looked like it didn't matter what diet you were on, shall we say, the ethos of that was, well, then if it doesn't matter about the diet, it's about the calories. But if you look at the standard deviation from the mean, in any of the diets, it was greater than the mean itself. And what that's saying is that there are some patients who did well on that diet, and there are some patients who did not do well on that diet. And you yourself just said that we need to take into account these personal issues. And we had an entire talk from Erin Siegel yesterday about those personal issues. And let me give you an example, because David did this study as well, and I did it as well in a different way. He did it with diet, I did it with drugs. There's a group of Quebecois, written up 2008, first author is Chaput. And what David and he showed was that they have an enormous primary insulin response, early insulin response to glucose. And the higher that insulin response went on a glucose tolerance test, the more likely they were going to gain weight on a low-fat diet. And the reason is because they're putting out insulin to beat the band, presumably because they have a vaguely driven insulin hypersecretion. So the point I'm trying to make, we did that with children with brain tumors. We gave them a drug called octreotide, which suppressed early onset insulin hypersecretion and demonstrated that we could get them to lose weight and feel better and improve their resting energy expenditure. In other words, it's not just how high your blood insulin is, it's how high your insulin goes in response to a glucose load. There's a secretion component, there's a resistance component. I believe in measuring both of those. You can do that off an oral glucose tolerance test, but you can only measure resistance off baseline testing. The point is, and David, I want your feedback on this.
Was there a question?
Yeah, there's a question. Yes, there's a question.
Not that I mind you talking.
The question is, can we, as a society, as a group of, we're not taking money, okay? We're not taking money, okay? We're independent scientists. Can we come up with a flow chart that can help people figure out who's who, parse the thing?
I have to say, there's so much ad hominem in the world of research, nutrition research. I'm really loath to say these investigators are on the take and therefore don't trust them, because it's never black and white. And there are people who do take money from the food industry who are doing, very good research.
Name one.
I'm not going to be ad hominem one way or the other right now, but I think the first place we have to start is, before we can ask nutrition researchers to give up industry funding, we have to provide an alternative, legitimate source of funding to them. We're presently spending a fraction of a cent in research, nutrition research, for every dollar of diet-related disease. It's a terrible policy. We need the government to be properly investing in nutrition research, and then once that research is in place, we can then say, all right, we're going to come in with much stricter stipulations for who can and cannot take research if you want to be part of this prestigious hospital or this prestigious academic community. I mean, anybody can take money and go do what they want, but that's got to come first. Until we improve the supply, I don't think we can choke off industry funding. That's my view. Last question?
Yes, hi. I'm Michael Coons, and I'm an intelligent lay person. I am...
You're a what? I'm sorry, you're a what?
An intelligent lay person with no medical training. I am wondering if the carbohydrate insulin model that you've kind of walked us through, as well as what really undergirds some of the interventions like what they're doing at Verta Health and JumpstartMD, is perhaps an incomplete model from a scientific perspective. Meaning there are important maybe things that you could add to it. For example, the effects of adiponectin, in terms of folks that are obese have low levels of adiponectin, There are interventions that you can use to target that, for example, exercise, glucagon, as well as perhaps taking the fact that, as an apple-shaped person as well, I probably do have higher levels of baseline insulin. I've been, anecdotally working with, a weight trainer and seeing very good results there. And I think possibly you could try to incorporate this into an effective behavioral intervention to say, well, you're going to be predisposed to anabolism. Why not use this to put on something that will raise your resting energy expenditure and possibly in the long run help you create that deficit in addition to like an Atkins style or a keto style diet? Thank you.
Yeah, great. I do want to say that the carbohydrate insulin model is not right. Well, it's not 100% right. There's inevitably going to be complexities. It needs to evolve. Obesity is far too complicated to be. A model is just a model. It's just one view of reality. And it's only useful if it guides hypothesis generation and advances science. And then the model changes. It's not, but I did try to emphasize that it's not about just one hormone or one nutrient. There are many factors that are environmental factors that feed in on our biology. Now, you mentioned adiponectin, and yeah, that could be an issue, ghrelin, PYY, GLP-1, but we haven't suddenly evolved to have inborn defects in our adiponectin regulation. Those are secondary. The point is that environmental factors or acquired dysfunction dysregulate the system. And how can we, without resorting to bariatric surgery, reverse this? And there's a plausible case can be made that for many people, greatly reducing the processed carbohydrates is going to set into action hormonal and metabolic changes that will make many of these missing pieces fall into place. Now, it may not always be the case. There are people who have hypothyroidism. They develop an autoimmune condition. Maybe some autoimmune disease is influenced by diet, but some isn't. And in that case, nothing you're going to do is really going to solve the problem until you get on the right dose of thyroid replacement hormones. And there are other issues. What I think is appealing about the carbohydrate insulin model is it offers a holistic approach to understanding why fat cells may be expanding in ways that don't have to blame just poor self-control in our modern food environment. And it's a basis for informing new studies and potentially new treatments in the clinic.